This is Dr. Chris Robertson providing the asthma lecture content. Asthma itself is a chronic inflammatory obstructive disease that is characterized by reversible hyperactivity of the bronchi and bronchioles to a variety of stimuli. Here you have pictured the normal airway, the asthmatic airway, as well as the asthmatic airway during an attack. So you can visually see what those differences look like. As with any type of condition that you're looking at, it's always important to recognize what guidelines you want to use to guide your practice, what evidence-based guidelines in particular. So here we want to look to the National Asthma Education and Prevention Program when it comes to asthma diagnosis, evaluation, and management. These guidelines provide a asthma care quick reference. This is what you can use. There are other references available. However, this is formatted for providers that you can reference in clinic. I believe it is a 12-page document that will take you through step by step. With outpatient asthma management, it's important to understand the components that you typically have a patient that is being seen for their initial visit, and then you have subsequent or follow-up visits after the initial appointment. Typically with the initial visit, and if that's the visit that you're seeing the patient at, or again, you may be seeing a patient for a follow-up visit, so you have to understand where that patient is in the continuum of care. So for the initial visit, it focuses on diagnosing the patient, determining the severity of their asthma, initiating medication, as well as demonstrating the use of those medications, particularly the inhalers, developing the asthma action plan, and scheduling a follow-up appointment. So those are things that occur with persons at the time of initial diagnosis. After they've been diagnosed and started on medication, you want to schedule the follow-up appointment. At the follow-up appointment, you're actually assessing and monitoring their control. So you're not establishing severity. Establishing severity occurs at the initial visit, but at the follow-up, you're now assessing their control of their disease state. And so at this time, you're going to also review their medications and any type of adherence issues, assess side effects, and again, review environmental controls. And this is when you will either maintain their therapy, or you may step up their therapy, or you may step down their therapy. So you may maintain or modify their management plan. This is also the time where the asthma action plan that was initially put in place at the initial visit will be reviewed, and obviously changes made as appropriate or as indicated. And again, you're scheduling another follow-up appointment. So distinguish the initial visit where you diagnose and determine severity and initiate treatment from the follow-up visit where you're actually evaluating control and making adjustments appropriately, and would then follow with continued follow-up visits. When you look at asthma, when it comes to your history and physical, you want to make sure that you tease out those things that, from a subjective perspective, that the patient's going to be telling you about, as well as the things that you would find on physical exam with respect to objective components. So it's important to recognize those things, particularly if you recall when you're going to distinguish asthma from COPD. So the subjective symptoms are listed here, as well as some of the objective findings. And one other thing with these symptoms, you want to make sure that you are questioning around the frequency of the symptoms, and also if you have a patient who uses a rescue inhaler, you also want to know if the rescue inhaler helps alleviate or relieve any of these symptoms. Again, this is a box or chart taken from the text that reviews some of those essential elements that you need to consider when diagnosing asthma. So, from a diagnostic standpoint, let's walk through what it entails for asthma. So, in order to diagnose asthma, there must be symptoms of recurrent airway obstruction. So you must see some of those subjective and objective findings. They must be present on history and physical. When it comes to spirometry testing, which is the second component of asthma diagnostics, keep in mind that in actual practice, you may see spirometry testing used. You also may see that it is not used. However, when spirometry testing is used with asthma diagnosis, there should be some airway obstruction or will be present. And so let me clarify that. When you see spirometry being used, airway obstruction is present. And so you will see reduced predicted value of the FEV1 FVC ratio. However, keep in mind that FEV1 FVC ratio may also be normal. And when you're looking at if it's normal, you're determining that based on their age. So when you look at a normal FEV1 FVC ratio by age, here you have a table that shows what is expected based on various age ranges, and you can see the normal decline that does occur with age. And so this would be the predicted normal FEV1 FVC ratio based on age, and then you would compare that to the patient's actual. And with spirometry, typically when you do the pre-post short-acting bronchodilator testing, you see reversibility. And the reversibility that you typically see in FEV1 FVC ratio, it is at least an increase and change of at least 12%. And when it comes to your FEV1, that is at least a 15% increase or 200 ml increase. The third component with asthma diagnostics, you want to make sure you exclude other diagnoses. So if there's a suspicion for COPD, CHF, PE tumor, concern with ACE inhibitor, airway edema, you want to make sure that you consider those things as well. I will mention here, recall that for asthma diagnosis, spirometry is not required. As it is with COPD. Spirometry is required to diagnose COPD from a guideline perspective, although you still may see some variances in practice. But for asthma, it is not a required component. Again, you're looking at symptoms based on history and physical. You can do the spirometry, recognizing it may be normal. You want to look at pre-post and see if there is reversibility with regards to short-acting bronchodilator, and you want to make sure that you exclude other diagnoses. When it comes to diagnostics, additional diagnostics, labs are not required to diagnose asthma. If you look at a CBC, you may see an increase in eosinophils. You also may see an increased IgE. When a patient has significant allergic status, that's when you would consider allergy-induced asthma and would likely send them for some type of intradermal testing. Chest x-ray you can certainly do to exclude alternative diagnoses or to evaluate patients for complication. However, when you look at asthma on chest x-ray, you may see hyperinflation or you may see thickening of the bronchial wall, but that's not to say that that will always be present. ABGs are only going to be indicated typically in an acute care setting. So that is a brief overview of diagnostics. Now let's move on to how we evaluate for asthma severity. So now that we have a patient who has positive history and positive physical exam findings, which could include spirometry, we've excluded other diagnoses. Now we need to determine exactly what is their asthma severity. So this table is taken from your text and it outlines the classifications of asthma severity. You have intermittent, you have mild persistent, moderate persistent, and severe persistent. You also have the clinical features before treatment with regards to what you typically see in these patients from a clinical perspective. These same clinical findings you also see here. This is taken from the guidelines quick reference guide that is available to you and is also posted with this lecture. So again, this is the initial visit where you're classifying asthma severity. When looking at this particular table, it is important that you note the ages. For purposes of this course, we are looking at adults. And so you can see at the top of this table, you can see the various classifications. You see intermittent, you see persistent, which has the three subgroups, mild persistent, moderate persistent, as well as severe persistent. And again, focus on the ages, which have the arrows at the top pointing down to the ages that are pertinent to the content for this course. And so when you look at these, you are evaluating impairment. And so here in this instance, you are looking at the symptoms. How often is the patient bothered by the symptoms? And you can see with intermittent, as it was displayed here on the table, it tells you how often the symptoms occur. And it also shows you underneath that how often are they waking up at night, how often are they using their rescue inhaler, are they having any interference with normal activity, and it also looks at their lung function measurements, which would either be the FEV1, the percent predicted compared to their actual, and then, or not compared, but based on the percent predicted, as well as the FEV1 FVC ratio. And so you take that into account, and you're also looking at, in the last year, how often have they had an exacerbation, or how often have they had to be placed on steroids. And so once you determine where the majority of their findings are, that is where you would categorize them. And so you would determine, does this patient have more mild persistent, moderate persistent, severe persistent, or does this patient have intermittent asthma severity? So this is how you determine asthma severity. Once you determine asthma severity, you see at the bottom where, I'm going to go back for a minute. Let's say, for instance, we determine this patient comes in and that they have mild persistent asthma. So once it's determined that they have mild persistent asthma, if you go to the bottom, you can see under mild persistent asthma, where it has recommended therapy, it says step 2. So we're going to follow step 2 in order to manage this patient. So again, now we're going to initiate medication and demonstrate use. So as I just mentioned, now once we determine classification of the asthma, you need to go to the bottom of this table to determine which step do you need to start this patient out on. As previously mentioned, I gave a scenario and said that the patient had mild persistent asthma. If you go to the bottom here, it says this patient's recommended therapy is going to be step 2. And so there is a corresponding page that gives you the details of the step therapy. And so you see here at the top, you see step 1, step 2, step 3, step 4, all the way to step 6. And so essentially, again, you go and focus on the age group, which for purposes of this course is adults. And they are at the bottom of the page. And so if we were to kind of plot, so you go over to step 2 and you go down to the bottom of the page, which shows you what we need to do for adults. And so that is how you initiate therapy. And using the stepwise approach and using this guide is a quick visual way to help determine severity and determine the classification, and also determine the initial management option. And you can see in adults, if this were the step 2, everyone is going to have a rescue inhaler regardless of what step they're at, but also you're going to use a low dose inhaled corticosteroid for mild persistent asthma. And so these tables are taken from your text. This goes over the medications that are used to treat asthma. It is important that you understand the indications, the formulations with regards to what comes in an inhaler form, what is a nebulizer form, what may be a syrup form, and also what the most common or major adverse reactions or prescribing considerations may be. So those things are noted here in these tables that are taken from your text. Again, this particular visual was taken from your text, and it is just another representation of the stepwise therapy. And it tells you that obviously for intermittent asthma, what step 1 is. If it's persistent asthma, persistent asthma, mild persistent, step 2, so on and so forth. So this also gives you another visual. One thing to note is that with all steps, and this is just another visual representation, at all levels patients will have a short-acting rescue inhaler. All steps have that. That is the one thing that is common to all. Keep that in mind. But again, this again shows the stepwise approach and which medications are indicated based on asthma severity. And yes, do note, all patients should have the rescue inhaler, but also each asthma classification or each level of severity does have certain med classes. You can see with intermittent, they're not on anything daily, but they do have the rescue inhaler. With any of the persistent asthma classifications or severities, there is an inhaled corticosteroid, but you can see with the moderate persistent and mild persistent, those are low dose. However, with severe persistent, that is a medium dose, whereas with severe persistent, again, depending on where they fall and what step they're in, if you have to step up, they're going to go to a high dose inhaled corticosteroid. So again, just remember the stepwise approach and the stepwise considerations. When you do see someone for follow-up, if they are well controlled, you will maintain them on therapy. If you have the opportunity to step them down, you see the yellow dots that make these arrows that go down. You also see Obviously, if you're stepping them up, you're going up to the next step in therapy, which is what we will get into in just a few minutes. But I want to get into the asthma action plan. So when you're developing your asthma action plan, one component that is important is the peak expiratory flow. Please note, this is used for monitoring of lung function. This is after diagnosis. This is not used for initial diagnosis. The peak flow is something that patients would use on an outpatient setting. They use in their home, at schools. This helps them monitor their asthma. And this is something that they would report or share. You can use it during follow-up visits or during a sick visit to kind of see where the patient is with regards to monitoring, but it is not used for diagnosis. It measures the maximum speed of expiration. And again, you're comparing it to a reference value in terms of what's predicted based on their age, sex, and height. Typically, there are charts or an app that you can use, and this link will take you to a website where you can enter the patient's age, sex, and height, and it will provide the reference value for you. Based on that reference value, again, you're looking at the percentage that the patient actually is able to perform. So based on the reference value, if they are within 80 to 100% of that reference value, they have good control. If they're within 50 to 79%, then they are considered in a cautionary state. This is where there may need to be adjustments to their medications, their lifestyle. You may need to look at, are there any triggers, and likely need an office visit, or definitely need an office visit if their peak flow is between 50 to 79% of the reference value. If they are less than 50% flow, that is a medical emergency and 911 needs to be called. So again, if a patient calls you and tells you that they feel like they may be having some asthma symptoms or an exacerbation, and you ask about their peak flow that they may have done at home and they tell you it's 40%, their next phone call should be to 911, or their first phone call should have been to 911 if they were following their asthma action plan. So this is what an asthma action plan may look like. And again, it speaks to the control. This is a little bit more specific in that it is going to focus more on the symptoms. And excuse me, the detail is provided here so that you get a sense of the symptoms that the patient may be having, so that it corresponds with the control that the patient may be experiencing. Again, if they are in the yellow, an office visit is needed because you may need to adjust medications, change something with their lifestyle, determine their triggers, and manage the exacerbation on an outpatient basis. And then schedule their follow-up visit. So again, at the end of the initial visit, the question is, when do I need to see this patient back? So no need to guess. Go back to the guidelines and see when the follow-up visit is recommended, and if a referral is needed. A lot of primary care providers do manage asthma. However, depending on the situation and circumstance, it would be appropriate to refer if needed. So keep that in mind. So moving on to asthma follow-up. So the patient has been seen, diagnosed, determined their severity. They've been started on therapy. They have their asthma action plan, and they were scheduled to come back. And let's say this is their 1 month follow-up. And let's say they had their prior visit with another provider, and you're seeing them for their 1 month follow-up. So again, your focus here is to assess and monitor their control, to review their medications, to determine if you're going to maintain therapy or if you're going to step up or down. Excuse me. To review their asthma action plan and to schedule their next visit. So there is another chart that is specific to assessing asthma control and adjusting therapy. specific to follow-up visits, and that is in the quick reference guide. And so you will note here that at the top, instead of saying severity, it speaks to control. So you will see well controlled, not well controlled, and very poorly controlled. What's important to note here again is to look at the impairment and also to evaluate risk. And then it also recommends the treatment options. So again, for adults, you will evaluate their symptoms. How often are they having symptoms? How many nights are they woke due to their symptoms? Does it interfere with their normal activity? How often are they using their rescue inhaler? You'll be looking at lung function, and there are also questionnaires that can be used as well. So when we look at the two things that are most different when you're assessing control and adjusting therapy, this is where you're going to be looking at peak flow and, as mentioned, the questionnaire. And so I want to highlight these two things. The questionnaires, there are a number of tools that can be used. And again, your choice of tool may be influenced by the policy at your site and may be influenced by the provider's preference based on the reliability or validity of a particular tool. So there's a number of things that may go into what the site chooses to use or what the provider chooses to use in assessing asthma control. And you can see some are specific to some ages, some only focus on adults, some focus on peds, so on and so forth. So again, once you determine the patient's control, are they well controlled, not well controlled, or poorly controlled, then you're going to determine their step therapy. And again, no need to guess. It is written in the guidelines for you, and it tells you whether you should step up, step down, maintain, and when you should see the patient back in the office. The other thing to keep in mind is asthma exacerbation. It's always important with asthma treatment plans that you educate the patient on the use of the peak flow meter, because again, that is how they will monitor their asthma outside of the office and in the home, school, work setting. But again, you can use that peak flow during a sick appointment. But the bottom line is, anytime there is concern for an exacerbation, and this diagram is taken out of your text, you always want to make sure that you assess severity. So this is where they would be doing their peak flow and looking at their symptoms, and you would determine how to manage. And this lays out the management option with regards to their initial treatment, which should be a part of their asthma action plan, as well as what to do if they have a good response, if they have an incomplete response, or if they have a poor response. When it comes to asthma, there is so much that goes with patient education and so much that is determined based on their self-care management. So it's important with diagnosis, and not just at the time of diagnosis, but throughout follow-up. It's important to make sure that you are continuing to support and educate your patient basic asthma facts, when to use their inhaler, recognizing symptoms early, how meds work, which is a really big one. There are a number of patients who will be on medicines that are supposed to be daily, but they only use them as needed. So it's important to have those conversations throughout and as needed. Vaccination is also a very big and important component. And so here are some reasonable expectations. This too is taken from your text in terms of what you want to tell the patient to be able to expect and what is reasonable for the provider to be responsible for. Lastly, keep in mind that there are risk factors for fatal asthma. And so be aware of those and how it even speaks to low socioeconomic status and urban residents. Be mindful of those things when you're taking care of those patients. If they've had 3 or more emergency room visits, 2 or more hospitalizations, how quickly they may be going through their short-acting rescue inhaler. But it's important for patients to also recognize this, and for you as providers to recognize those risk factors associated with asthma fatalities. And this concludes the content on asthma.